Okay, so we're going to talk on some diagnostic and therapeutic procedures and how to plan and execute. This is going to be a very general talk because we cannot really get into too many specifics here. So I'll try and see how quickly I can finish this because I think it's getting too late. So why is the discussion? Because ECMO, we know, are the slides moving, sir? Hello?
Yes, sir. Yes, sir.
Yeah. Okay. So there's a lot of anticoagulation going on. There is bleeding risk when we do these procedures. There is also a risk of transport because all procedures cannot be done at the bedside. There is risk of infections, risk of mechanical complications, including cannula clotting and the circuit clotting. So there are a lot of things that can happen when we do procedures, and that's why it's important to be very careful on how we do it. And also there are enough studies to say that when procedures are done in patients on ECMO, there is also risk of increased mortality. So that's the bottom line of all that. The structure of my talk will be, why procedures are needed, what categories of procedures are done, general rules and preparation, and some specific procedures we'll have a brief discussion on. So procedures, while on ECMO is one aspect of it, but we do go on ECMO for certain procedures just to make the procedure safe. The common ones are, airway reconstruction surgeries, extensive lung and airway tumor resections, bronchopleural fistula repairs, and surgeries involving heart and great vessels. So the two categories of procedures for which ECMO is done. Just to share, this was one of our patients who had who had a huge bronchopleural fistula to begin with. This was a huge hydrated cyst to begin with, and during surgical resection developed bronchopleural fistulas and could not be ventilated, and that's why this child had to go on ECMO for cyst removal and also fistula repair, and after 2 days was come off ECMO. So this is one of the situations where ECMO helps in making the procedure safe and keeping the patient alive. So this is one of the indications where we can go on ECMO to save lives. So we need to ask 3 important questions when we plan procedures. Question number 1 is, can the procedure be avoided? Second is, when is the best time to do the procedure and who is the best person? So these are very important questions that need to be answered before we plan the procedure. And like I said, there are different types of procedures. One is the emergent indications where, these procedures are extremely important to keep the patient alive and also to make sure the ECMO works well. So if you have a huge pericardial tamponade or a tension pneumothorax, you're going to have problems with flows and you'll not be successful in, carrying on with the ECMO, treatment. And that might significantly impact outcomes. So these are called emergent indications where you cannot waste too much time and you'll have to go ahead and do these procedures in order to be successfully coming out of ECMO. And then there are certain indications like fasciotomy for compartment syndrome where it can become limb threatening, and then infections and quality of life, all that can get affected. So those are other indications. Then there are some procedures which are really essential but not emergent. That means things like therapeutic bronchoscopy, where it's not emergency that has to be done, but of course they are important for you to enable successful recovery for which you have put the patient on ECMO. So these are procedures that way. And then there are certain procedures which are essential but can be avoidable. Something like tracheostomy or a routine bronchoscopy or routine change of lines and things like that. So one has to understand when you're planning a procedure, which category does this procedure fall into, and based on that, we'll have to make a choice. Now, when we come to emergent indications, the first and most important thing is that, a proper discussion with the family. Preferably have a video counseling, consent forms properly signed, where we discuss about why we are doing the procedure, what is the indication, how we are going to do it, and who is going to do the procedure. I think not only just the father and mother, because pediatrics, they are the primary decision makers, but it's always good to have an extended family for the discussion, because if something goes wrong, it's usually the extended family which creates trouble and not the parents themselves. So we need to clearly explain the risk of the procedure, what are the possible good outcomes and bad outcomes. It's very important with clarity. Explain the bleeding implications, what precautions one is going to be taking, potential impact on outcome, and also cost implications. So all these need to be clearly discussed, documented, and preferred would be to have a video counseling before we go into these adventures. The second thing is to prepare well. How much ever you prepare, it's never sufficient, but we have to make sure that you have enough team members. The first team has to definitely take care of the patient to stabilize the breathing and circulation as needed when the procedure is on. Then we have the surgical team and the cannulation team, and also the perfusionist team who have to be available at the bedside during the procedure. We need to plan equipments very well, not only the ECMO and circuit, disposables and backup circuit, but also the equipments that are absolutely required for the procedure without any compromise in the size or quality of these equipments, because you only get one chance to do this. And then, of course, we have to decide on the location. So most of the times it is preferable to do these procedures at the bedside, because then you don't have to have the risk of transporting this patient, but that may not be always possible. We may have to take some of these children to cath labs for the safe and successful, undertaking of the procedures. Some of the times we may have to take them to the operating room or the imaging room, like CT and MR, CT, for us to be able to do these procedures. And having the right personnel, communicating with them, and because these anesthesia teams in a lot of hospitals may not be in touch with the patient, may not know the patient. It's only during the procedure that they come and interact with the families, and they need to know exactly what is going on. It's always better for the PICU team, which is regularly taking care of this patient, to be with this team when the procedure is going on, so that they can have, share valuable inputs. The general protocol and precautions need to be followed. The first and foremost thing that we are worried about is bleeding. So we need to take measures to prevent bleeding. If it is major procedures, it is good to stop heparin for a sufficient amount of time. And the ECMO can be run heparin free with all the new circuits that are available. We aim for lower ACT targets in these situations to reduce the risk of bleeding, and optimize coagulation numbers reasonably before starting the procedure itself. The second thing is to prevent clotting of the circuit and cannula. So when we, back off on the heparin, it's always good to run high ECMO flows, so that, there is no stasis of blood happening. That itself, to a great extent, can prevent circuit clotting and cannula clotting. We need to keep a close watch on all the pressures, P1, P2, P3, and delta pressures, to see if anything is going wrong, and take, preemptive measures. Inspecting the circuit becomes very important during these times, and we should have a standby fresh primed circuit in case there is any problem with the circuit or cannulas. Addressing bleeding when they happen is another important thing. So we should have a proper plan. TEG or ROTEM, if you have in your units, that's the best way to guide blood product transfusions. Some of these patients may need protamine to reverse heparin, and judicious use of tranexamic acid, fibrinolytics, can help, address the bleeding issues. And of course, the most important thing is strict asepsis, and team dynamics is very, very important. We need to communicate, because there are multiple teams involved in these situations, and a good proper communication is very, very important between the teams, and also between the teams and the families. Now, essential procedures. The best time to do these procedures, I'm talking about those which are not emergency. If we can time them well, that is the best thing. So the best time to do will be pre-ECMO initiation and post-weaning, if that can be done. So simple things like insertion of chest tubes, nasogastric tubes, arterial lines, CVL access, all these need to be done before going on ECMO, at least about 4 to 8 hours prior, so that, once we heparinize and we go on high doses of heparin, there is no bleeding from these areas. If there is not possible, if we have to do some of these procedures post ECMO initiation, the best time would be the initial 1 week, because what happens beyond 1 week of ECMO run is a lot of coagulopathy issues that can come up because of the the duration of the ECMO run itself, and the circuit, and a lack of anticoagulation there. So that is why it's important to time these procedures very well. And like I said, the best time would be to before ECMO initiation, or if you can postpone these procedures post ECMO wean and coming off ECMO, that will be the best and the safest thing to do. Now let's go through some specific procedures. Radiology procedures are very common. Bedside X-ray, ultrasound are absolutely safe, but we need to be careful when we position for X-rays that the doctors are there. The cannulas should not get dislodged. That can be very, very tricky. So we have to be very, very careful. CT chest is also safe, but the risk involved is of transport. So a good team discussion and planning, and we need good coordination between the teams, radiology, ICU, perfusion, and surgical team. Remember, if you have to do a CT angio or contrast study, it's important to talk to the person who is actually the radiologist who is going to be there, because especially during VA ECMO, when you give contrast, the timing of the images is very important, because the blood flow dynamics are very different when we are on ECMO. So that's why it's important to have a proper conversation, what you're looking for and what is it that you want to understand from the studies. Of course, MRI, we don't have MRI compatible machines, so those will not be possible when we are on ECMO. Transesophageal echo is another thing that can be done, but commonly we end up doing transthoracic echo. So the anticoagulation is not a contraindication. It helps us understand a lot of residual defects in the heart. It helps us guide the septostomy procedures which are done by the surgeons, and very useful for weaning from the ECMO when the cardiac functions can be better assessed and analyzed. So needs a risk-benefit discussion if we are going to be using transesophageal echo. Bronchoscopy is a common procedure that is done. Some units do it as a routine thing. Some units do it when they have X-rays like this, especially when we know that the lungs are not opening up. It could be a simple thing like secretions blocking the major airways, and clearing these secretions may help lungs recover. Some of these children may need repeated sittings of bronchoscopy. Overall, it is safe. The main thing is the risk of infection, for which we prefer using disposable bronchoscopes, which are not very expensive, and have a dedicated bronchoscope for a particular patient. The challenge in children is that we need to have appropriate size bronchoscopes. The smaller the kid, the more challenging it becomes. So it's important to have different sizes of bronchoscopes in pediatric age groups so that we can successfully do these procedures. This is one of our patients undergoing a bronchoscopy procedure. We see the pulmonologist doing it for us, and the pediatric ICU team closely monitoring and supporting the whole procedure. Cardiac catheterization, different indications are there. I'm not going to specific indication, but the challenges are that if we have to move the child to the cath lab, transport is a risk. Vascular access can be challenging because you already have multiple central vessels accessed, one artery vein or two central veins. There can be a central venous cannula in another vein. So vascular access can become very challenging. They can result in secondary limb complications, formation of thrombus, and also compartment syndromes and other things. And air embolism can be a specific risk in these procedures, but it can be safely done with adequate precautions. GI procedures, as simple as a nasogastric tube insertion can become very, very catastrophic when they're already on ECMO and with significant heparinization. It may be better off doing a orogastric tube insertion rather than a nasogastric tube insertion with direct laryngoscopy technique to minimize the trauma and the risk of bleeding. Endoscopy can be done with adequate precautions. Even endoscopic electrocautery can be done with adequate precautions as part of the A procedure. And this can be done bedside in most centers. But if that kind of equipment is not available, then additional transport risk is there if bedside facility is not there. Chest drains, we should be limiting it to only those situations where it is compromising lung expansion or ECMO flow. So if you have a huge tension pneumothorax or a significant pleural effusion that is causing problems with flows, small pneumothoraces or small pleural effusions are preferably left alone to be addressed later if required, because the risk of bleeding is quite significant when it comes to these interventions. And if you have to do it, then we have to take all the precautions to ensure the coagulation is good, and with good backup of blood products, and preferably it should be ultrasound guided, and pigtails are preferred over thoracotomy or VATS. This is one of our patients who we burnt our fingers with, who underwent VATS, and you're seeing this is the red areas that you're seeing are huge hematomas inside the thorax. The heart is completely compressed, the lungs are completely compressed. So these things can happen despite all adequate precautions that you've taken. So you have to be really, really thinking very hard and looking at alternatives if you have to do any of these procedures. Tracheostomy is another common procedure. It is done to wean sedation and for better toileting. Again, the best time to do it would be in the first few days of ECMO run or post weaning of ECMO if possible. Really, there is no benefit in doing tracheostomy if the lungs are not improving. It should not be just based on the number of days of mechanical ventilator support. To minimize the risk, you have to time it very well. But if it has to be done, then stopping heparin 4 hours pre-procedure, and then holding heparin for a couple of hours after tracheostomy and maintaining lower ACTs for at least 12 to 24 hours may significantly prevent the risk of bleeding in these patients. Again, thoracotomy, just like chest drains, significant risk of bleeding. So really it has to be a proper good indication to do it. Like in the patient that we spoke about with the hydrated cyst and the significant bronchopleural fistulas, there was no other option but to go for it. Sometimes airway reconstruction surgeries, esophageal surgeries, to do these surgeries safely without causing any life-threatening problems, we may have to go on ECMO for those indications per se. In those situations, we'll have to take adequate precautions, and it can be done. And there are several case reports of successfully being able to do these procedures without and saving the patient's lives. Neurosurgery, again, we'll have to weigh the risks and benefits, but more important is to understand the prognosis and prognosticate if there is significant bleeding. So then we'll have to consider coming off ECMO or running without heparin during this time if we are going to give a chance for the patient. And the earliest we come off ECMO, the better it will be for the child. But again, it depends on the primary indication and what stage of ECMO you're in terms of either cardiac or lung recovery. Abdominal surgery interventions also may be required, especially in abdominal compartment syndrome situations. But of course, in these situations, most of the time we are able to manage with other supportive medical measures and having drains inserted in a safe way under ultrasound guidance. Again, proper selection of patient and managing anticoagulation well during this period is very, very important to minimize the risks of the procedure. A small note on intra-hospital transport and risks associated. So if we have to move the patient to the cath lab, the OT, or the imaging room, these are the risks that can come with it. They can have flow-related issues during transport just because of the cannula positions getting altered during transport. There can be kink in the circuits, kink in the cannulas. Intravascular volume status may be another reason for flow-related problems. So we need to go prepared to support, intravascular volume. Power failure is a real problem if the battery backup is not good. So ensure you take your hand crank along with you and have a power backup if possible. Hemodynamic fluctuations are known to happen, especially hypertension, because we are disturbing this patient from the area and we are actually moving the patient down. So we should have adequate analgesia, sedation, and also carry vasoactive medications in case there is hypotension during the procedure or while we are transporting. Oxygen issues can be there, so we need to have a good cylinder backup. Bleeding from cannula sites can happen because of the disturbance in the cannula positions. Dislodgements of lines and tubes can become a reality, so one needs to be very, very careful when we manage this transport. So take home message, procedural interventions on ECMO has high risks. So ask yourself if you can avoid it rather than asking, is it needed? I think that's a very important question. Best done pre-ECMO initiation or post-decannulation, or if it cannot be avoided, maybe the first few days of being on ECMO. Proper discussion needs to be had with the multidisciplinary team, and we need to plan very well and prepare very well. That's very, very important. Counseling is extremely important. No matter what you think about the risk, you may have done these procedures many times before, but every time you do a patient, each child or each patient is different. So make sure that you speak to the families and state facts and document these very well. Risk benefit analysis has to be done for every patient, for every procedure. It should not be per procedure, it should be per patient as well. So thank you very much.